today, and as usual, it's great having at least one colleague from the US, Bart Taylor, who's our discussant, and some colleagues from Denmark. That's fantastic, and thank you so much, everybody else who's joined. Welcome. I just thought I'd show this slide, which is the homepage for our new website for our centre. If you'd like to look at this in more detail, and here are the partners for our centre, both the university partners and also the health service partners. It's the case that myself and some of my team are currently transitioning to another institute, the Baker Institute, so they'll become a partner in the future as well. So we've got a nice mix of institutes and health services that are part of our CRE, and this will expand over the next year or two as well. The topic for today is to talk about work that my team has been doing over a number of years, really looking at this issue of a number of years ago was called telephone coaching, and in more recent years, as you'll see, has sort of transitioned into developing and evaluating automated coaching programs to improve diabetes management. I'll kick off the presentation, then Enying Gong, who's a PhD trainee with us and also one of the trainees from our NHMRC Centre, will talk about some of the research work she's been doing for her PhD on one of our automated programs. And then at the end of our two presentations, we are delighted and very happy that one of our senior researchers from our centre, Bart Taylor from Stanford University and Palo Alto University, will be a discussant, and I'm sure we'll make some very provocative comments, and then we'll have some open discussion. And if there's questions or comments you want to make along the way, feel free to put those in the chat, and we'll pick those up at the end. I also wanted to acknowledge that actually some of us, myself, Bart Taylor again, Enying Gong, also Dominika Kwasnica, one of the research fellows for our CRE, were involved in a symposium which was conducted last week as part of the US Society for Behavioural Medicine. So we're kind of touching on some of what was talked about at that symposium and some of the issues we discussed. This is really the sort of three take-home messages, if you like, which we'll address in more detail through our presentations, which is that automation is becoming more and more important as an important component part of digital health programs and their delivery, and I'll explain how we've incorporated this into our programs. Secondly, one of the big challenges or issues is how the technology that we use for enabling the delivery of healthcare programs can become more human-like from the point of view of the experience of the participants, and I'll talk a little bit more about that later on. And then, as will become clear by the end of this session, we're now sort of transitioning into this very exciting opportunity in the development of sort of digital technology with the advent of chatbots and virtual avatars and conversational agents. And this is work that you'll see has been incorporated into the second of the programs we're going to talk about in a little bit of detail that Enying's going to talk about, My Diabetes Coach, but we can come back to that later on as well. my first point to make is the idea that human speech and conversations can be human-like and important goes back a long time. It's not as if we've only thought about this kind of technology, since the advent of the smartphone or Google in the last 10 or 15 years. In fact, it extends right back to the work of the inventions of Thomas Edison, and not only related to his refinement of the use of sort of telephones and so on in the early days, but actually the phonograph and actually recording human speech and conversation, and that he was really trying to replicate human speech in those recordings. And in fact, one of his really interesting adaptations or attempts was to create dolls that could make human-like speech. I won't play any of the recordings because they're really actually pretty creepy. And in fact, he actually developed a company to sell these dolls, but children found these so creepy that they actually stopped manufacturing them. But they used to sing many different songs and or read stories and so on. So it's kind of quite interesting, this part of history. But anyhow, back towards the present. Bar Taylor and myself wrote this chapter called Using New Technologies to Improve the Prevention and Management of Chronic Conditions in Populations about 5 years ago for the annual reviews of public health. And Bar, I can't believe that this sort of seems like a generation ago. And when I read this chapter again, 5 years later, there are some pretty naive statements in there, which I guess reflects how quickly technology is moving. But I guess what we were trying to express in this chapter is that if we could kind of harness new technologies, there's a whole lot of stuff we could be doing in disease prevention, health promotion, and chronic disease management, which could be really exciting and actually engaging populations, define populations, delivering potentially more sustainable interventions really at scale, and the sorts of dreams that people like Bar and I had 30 plus years ago to deliver sort of interventions to populations. Potentially now we've got the technology to do this, and this is the potential or the promise. And the question is, how are we doing with the reality? And that's sort of something I'd like to reflect on during the two case study examples Enying and I are going to give today, and then I'm sure Bar will have some musings about this, and then we can talk about this in the discussion afterwards. And at the end of the day, what are we trying to do? I mean, we're trying to help people with what are usually complex chronic conditions with many different sort of comorbidities, often combined with chronic distress, people feeling very stressed, anxious, often panic attacks, depression, and other symptoms of mental health conditions. We're trying to help people with their lives and to live lives that are meaningful, important to them, while also keeping their doctors and their health professionals happy by achieving good clinical results and health outcomes. So in order to do that, we need to be able to create and develop and provide access to programs and sort of digital resources and supports which achieve fantastic reach in populations, great uptake, are really very engaging for people to use. The programs have impact, and they're effective, and they're affordable, so access for all, and sustainability is great. I mean, that's sort of the holy grail. And you know, for those of you who sort of work clinically, you know what the issue is, that for people with a condition like diabetes, this is something that people are living with 24 hours, 7 days a week. And of all of that time, there's a little bit of time each year, you know, if people are pretty well managed and doing okay, maybe 6 hours, maybe 12 hours of interacting with their doctor and other health professionals. But for the majority of the time, people are trying to do all the stuff by themselves, you know, the self-management piece. And again, an article that Barr and myself and a number of his US colleagues wrote last year, talking about how technologies can be used and the kind of analytics and the data and the information generated by these programs can be used to really optimize people's experience of the programs over time, and to optimize their delivery to maximize the reach, achieve good engagement, uptake, and you know, impact and outcomes. And in this article, we sort of describe a process for doing this and how this can be done in real time to improve program delivery and uptake and the outcomes of programs. So another way of sort of framing this question is to say, well, can technology really deliver sustainable human touch kinds of programs? And in fact, this sort of high-tech, soft touch kind of notion was actually when I was in China, talking about some of the technology we were developing and trials we were doing about 10 or 12 years ago. And in the middle of my presentation, one of the professors who was in the audience at Shanghai Jiao Tong University in Shanghai, she said, oh, Professor Brain, what you're talking about is high tech versus soft touch, you know, and soft being the human touch, which I thought was a really neat way of expressing what we were talking about. Because if there's not the soft and human touch that people feel when they engage with these kinds of programs, it's really very unlikely that there's going to be sufficient engagement over a long enough period of time to actually make a difference. Now, over the last 20 years, there've been 5, I mean, I've been involved in many more sort of technology delivered programs and collaborations with others, but there's probably 5 that have really stood out for me, and this is the list of 5. The first 3, Proactive Heart, Logan Healthy Living Study, Mid-Care Heart, I'm not going to talk at all about those, and those programs were all more than 10 or 15 years ago, and they were all really human coaching, telephone delivered programs. So what I am going to talk about now is I'm going to talk about TLC diabetes, which was the first automated conversational coaching program that I was involved with, and then Enying's going to talk about My Diabetes Coach. The telephone linked care technology and program was really just came up serendipitously or opportunistically from just talking to a colleague at conferences, a guy called Rob Freeman from Boston Medical Center in the US, and he and I used to regularly attend the US Society for Behavioural Medicine conference each year, which has always been my favourite annual US conference that I've been missing for the last year. And even though we had a wonderful virtual experience at that conference last week, it's not quite the same. But sort of Rob and I would just sort of talk at these conferences over 4 or 5 years, from about late 90s to about 2003, 2004, and I'd go along to these presentations where he was talking about this TLC technology that he developed for his for delivering kind of behavioural intervention programs. And as I came to sort of understand more about what in those days was interactive voice recognition programs and the scripts he developed for these programs. I then thought, well, this would be really neat to kind of adapt this technology and this kind of program to chronic disease management. And that's kind of what we proceeded to do from about 2004 onwards with other colleagues in Queensland. And essentially, at the core of the program are these more than 2,000 little strings of speech, of sort of human conversation, which are all recorded. They're actually they're recorded as human speech, and then the program listens to how people respond to these questions or comments. People are invited to give answers either by speaking or responding in multiple choice or by touching a keypad. That's essentially what it is. And the programs. And the program that we started delivered, we first tested a pilot program for improving physical activity, and then a program for diabetes. The program is essentially monitoring how people are going, getting feedback on how much activity they're doing or how they're addressing certain behaviours or actions related to diabetes. It's providing some education and knowledge about diabetes education, and then it's kind of coaching people to make changes, to set some goals, do some tasks, and then the next interaction to give feedback. That's essentially what it is. So we developed this TLC diabetes program that had modules addressing self-care behaviours related to blood glucose testing, nutrition, physical activity, medication taking, foot care, and emotional health. And this is the program, the simple program design, with a technology system, the user interacting, dialing into the system, talking on their telephone, a coordinator in these days, it was quite a primitive dashboard to monitor people's interaction with the program, any technical difficulties they were having with the use of the program, or if there were any clinical alerts from the program, and then there were regular reports sent to the person's health provider with their permission. So these are the components. The other part of this program, which was really pretty novel at the time, was that we also linked it to people taking their own blood glucose readings, and those programs also being incorporated into the conversations that people were having with the TLC diabetes program. So the program was able to monitor how often people were testing, and what the results of the tests were in terms of blood glucose. And then maybe I can just very quickly, let's see if this works. So this is an example of a conversation. Six times a week, let's say. So you can get the idea, you can see that specific behavioural strategies are being used. So you get the idea that the person is interacting, giving responses, and then the way they respond personalises and tailors the program for them. We then adapted this program, tested its acceptability, feasibility in Australia. We then built this Australian TLC diabetes program, and then we undertook a randomised trial where we compared the use of people using this program, people with diabetes compared to usual care, and we also did an economic evaluation as well. And we determined how often people would have access to the program and their interaction with the program, etc. So the long and we've published all of these results and findings, and happy to share the relevant papers with people. But the bottom line is that for the people recruited, they were able to achieve better control of diabetes, well, at least HbA1c levels than was the case with the people in the usual care condition. And also there was a relative improvement in people's mental health functioning as well, which was quite interesting. What really blew us away actually was how often, how much use people were making of the program and how much they were interacting. So they were completing the majority of the calls, so the calls and the modules were tailored for them in terms of their behaviours and lifestyles, which had goals set by their health professionals. So, you know, people completing around 3/4 of the calls. Average duration of calls 10 to 12 minutes. So if you sort of do the quick sum, it's sort of between 170 and 200 minutes of interaction. You know, which what blew me away was comparing that to the results we were aware of 10 years ago in terms of people's use of online programs. And if you can get people interacting for 200 minutes with online health programs, then I think you're in the top 5% of performing programs, because it's pretty unusual. We also obtained some quite interesting economic data on the sort of costs of the program and how this might have benefited other healthcare delivery. Then the other aspect was just the feedback on people's satisfaction with the program, its ease of use, their confidence, their motivation. And these were not, you know, average age, 60 to 65 years. 5-10 years ago, this would have been the first time that the majority of the participants would have used any kind of technology like this for managing their health. It's a bit more common now, but 10 years ago, this was definitely not the case. What was really interesting was the more qualitative findings about what people were saying. You know, good to know someone's keeping an eye on me. So this is an automated conversation people are having. It's helping me dot my I's and cross my T's. Speaking with the computer is good because it reminds you you're managing diabetes for yourself. You know? So if you could get people responding to a diabetes educator or some other kind of health professional they're interacting with, you'd be very happy if people were responding in this way. A number of the people were living in country areas and didn't have access to diabetes educators or any other support. In many cases, people didn't even have good access to a GP. So we got very good testimonials and feedback from people, and we subsequently went on to publish a number of the papers from this study. And what we concluded was this was kind of interesting, because this is this is almost 10 years ago. This is a great way that you could provide, 24/7 kind of help to programs to people, low cost, easy to use, seen at least in the short term. We don't know about the longer term outcomes, improved diabetes control, and maybe there were some economic benefits as well. So we were very happy with those results. And then we thought, roll forwards to 5 years ago, where smartphones were now much more common and different kinds of technologies available. We thought, well, let's give this program a refresh and move it to a more contemporary technology base. And I'll now pass to you, Enying, to share your screen to present the My Diabetes Coach trial. Are you going to do that now?
Yes, thanks, Professor Oldenburg. I'm just sharing my screen.
Thank you.
Yeah, thanks, Professor Oldenburg, for sharing with us. As he just mentioned, the program that I will introduce called My Diabetes Coach, which is a program that has been adapted from the TLC diabetes to make it more enabled for internet-enabled devices and to provide more accessible and engaging self-management solutions and resources for people with type 2 diabetes. And the development of this program actually is around 2015, 2016, including adapting some new scripts from the TLC program and also designing an app with the most advanced technologies that were available at that time. The development of the program was also supported by the research team that led by the Professor Oldenburg and also teams of researchers from many other universities, and also technology and medical partners in co-design the whole program. And as shown in these figures, the program consists of several interrelated components and support people with type 2 diabetes. And the structure actually is kind of similar to the TLC program that Professor Oldenburg just shared with you. The core part of the program is an app that is accessed via smartphone or tablet to enable users to participate in a series of interactive sessions to improve their self-management. And the app could also link with blood glucose meters to upload and sync readers through Bluetooth, or the users could just upload the readers into the app. Users were also provided with a user guidebook and a website that contains links with online discussion board so that they can also access to some updated information and also share their experience with peers who is also using the program. A program coordinator was also assigned to provide some technical support or some other required human assistant to the users. Apart from these new elements, users were also access to the services that were available by the National Diabetes Service Scheme or some other healthcare services provided by the GPs or specialists as part of the usual care. And the mobile app was very innovative as it used voice recognition software, pre-scripted conversational elements, and script logic to deliver personalized support, monitoring, and advice via this animated interactive virtual agent named Laura. Laura is an embodied character with a range of facial and gesture animations. It could deliver spoken dialogue and response in real time with users when the users speak to the program or touch the buttons. The sessions of chatting with Laura could happen anywhere and anytime when the user has a need. And the number of sessions and some of the content was personalized based on the recommendations from participants or GP. Reminders and alerts were also sent to the project coordinators and the GPs if there is a technical issues or some clinical issues that need human support. The chats with Laura mimic the appointment that made with healthcare providers or diabetes educators. Following the instruction given by the Laura, users could review their progress and performance since the last communication with Laura, and they could revisit the goal settings and also discuss some challenges they faced in making or maintaining their behavior changes. The sessions covered a range of self-management activities, including healthy eating, physical activities, blood glucose monitoring, medication taking, and food care, which actually is very similar to the TLC diabetes program. At the end of each sessions, participants were also required to complete quizzes with some gamification features to ensure that they acquire the knowledge and they are capable to manage their self conditions. Similar to the TLC program, we also evaluate the My Diabetes Coach program through a randomized control trial, and we recruited participants across Australia through online channels. After the screening, about 187 individuals were formally enrolled in the trial. The participants had an average of 57 years old, and about 40% of them recently registered with NDSS within 1 year after their diagnosis of type 2 diabetes. And the intervention were delivered at home settings among 93 participants who were randomly allocated into the intervention arm. And the evaluation were lasted for 12 months, which through the 12 months, there is limited interaction by the research team. So it is more close to the real world scenario, except the follow-up visits at the 6 months and 12 months. Through the evaluation, we found that the intervention did improve the blood glucose control, but unfortunately, the effect size was relatively limited than expected, and the differences between the two arms was not statistically significant. However, the intervention significantly improved the health-related quality of life among users, and both the physical and mental health dimensions was significantly improved by the intervention, and the impact was maintained over time. Over the 12 months, participants completed about 18 chats with Laura, which reached to about 4 hours of duration of chats. And this amount is actually quite large and significant, which was similar to the maximum amount of group sessions that people with diabetes could be offered by the Australia Diabetes Program through human delivered sessions. And the number of chats from the MDC program is similar to the TLC program, but the duration of chats was slightly longer. We also took a further investigation on the program use and the maintenance. From the Google Analytics data, we found that some of the participants turned into inactive users after several months of program access. And in the end, about 40% of participants could maintain their program use with at least 6 chats with Laura over the second half of the year of the program access. And such program use provides some explanation for us about the limited effect size on the HbA1c, as we found that people who could maintain the program use were experiencing a larger effect size at 12 months. We also do some surveys about users to understand how they think about Laura and how they interact with Laura. We found that many participants believe that Laura is helpful, competent, friendly, and trustworthy. And another PhD student, Shara, also conducted some in-depth interviews among users, and she found that the participants have different perceptions or preference on Laura as either health professionals or peer friends. We also measured the interaction with Laura at the 6 months of the intervention, and many participants reported that they feel motivated, comfortable, and confident when they interacted with Laura, while some users had some negative feelings when they chat with Laura, especially they feel frustrated or guilty when they cannot achieve the goal that's suggested by Laura. Built on previous literatures, we also look forward, we will also pay some attention to engagement as a key concept that has been highlighted by both behavioral medicines and also computer science. And engagement is a concept that developed to cover both subjective experience characterized by attention, interest, and affect, and the objective engagement behaviors as the extent of using the program. We conduct secondary data analysis of the trial to generate an engagement index and try to explore the association between the user's engagement and program maintenance and the effectiveness of the program. We found that people who were elderly, being female, and have a higher technology literacy before the program may have a relatively higher score in the engagement index, which is consistent with some of the previous research findings. Specifically, people who were elderly rated higher on app satisfaction and reported more positive affect when they interact with LoRa. We also found that the engagement index was associated with maintaining program use and could be a key factor that may influence the effectiveness of the program in long term, and which may provide us some clues to optimize the program in the future. From both the quantitative and the qualitative data, we also found some interesting findings about the mechanism of impact. We found that people who rated highly on apps engagement, enjoyment, and when people rated, they were more motivated by LoRa, and they also experienced a greater reduction on the HbA1c at 12 months. Some users reported that the process of interacting with LoRa was engaging, as they are not only read the scripts, but also see LoRa as a person or is talking to LoRa. And the feeling of someone is behind line and helping them made them feel emotional, supportive, and motivated, which empowered them to on the track of doing check-ups to maintain their behavior change and also be more confident in dealing with daily activities. Not surprisingly, we also found that there is diverse needs from users, as some people may prefer read the text than hear it, and the translation procedure from knowledge to behaviors also highly rely on participants' self-efficacy and self-autonomy. Some users were expected more interaction with the program, not only limited to the program itself, but also through the program to link with broadly with the healthcare system and other health services that is provided by the GPs or diabetes educators. As a kind of summary, the MDC program optimized the previous TLC program with more engaging features and delivered all the conversations through LoRa, this avatar agent. And people could access to the program with anytime, anywhere, and with more engagement and a higher acceptance. However, we also face a lot of challenges in maintaining the program use, and some future optimization of the program could lie on the strategies to design more engaging and more personalized features to fulfill the diverse needs and preference from the users, and to integrate the program broadly with the healthcare systems. So that's my presentation, and I will turn it back to Brian.
Thanks very much, En-Ying. And as I think I mentioned at the beginning, En-Ying is a PhD student with us, just finishing her PhD in the coming months, and is also one of the trainees from our centre. I'll just show a couple more slides, and then I'll pass it to Bar for his comments. Oops, sorry. Just jumping around my screen. Sorry. Folks, see my screen again?
Yes.
Okay. Okay, let me just go to that. So I just wanted to sort of finish up and sort of highlight what I said at the beginning, and Barb will probably comment on this as well. You know, this, I think, yeah, the future is really going to be around chatbots and virtual avatars and conversational agents, and really looking at sort of technologies which can take these kinds of programs to scale, and the learnings that we've acquired from these sort of targeted sort of studies and technologies can really then have dramatically improved reach and uptake. And in fact, a few of us have led by Tilman Dingler, who's a lecturer in computing sciences and involved with our CRE as well, Dominica, Jingwei, another student, Enying, and myself just submitted this article on the use and promise of conversational agents in digital health to be published in the Yearbook of Medical Informatics, which is co-edited by one of our CIs, Annie Lau, and really sort of talks about these issues as well. Before passing to Bar, I just want to personally acknowledge just everyone who's been on this journey with me for the last 15 years, many research collaborators in Australia, the US and other countries, lots of research colleagues and staff, trainees and students, Enying and others before her, and just lots of different funding sources from NIH and MRC and elsewhere. And yeah, I wanted to acknowledge Yu Wen, who is another one of our trainees who helped me put this file together. So thanks very much, Yu, for assisting with that. So I'll finish there, Bar, and pass it over to you.
Oh, thank you, Brian. I'll be very brief. I think I have about 5 minutes and we want to have a discussion. First of all, you know, I've followed this journey. This work is really spectacular. I think everyone who's been involved with it should be incredibly proud. It's interesting. When Brian first talked to me about this a long time ago, I thought the conversation we would be having today would be that there would be hundreds and hundreds of randomized trials as elegant as the ones that we've seen. It would really help us begin to understand how we get the dream of leveraging what we do for larger populations. And I guess my first point is, as you were talking, Brian, I began to do a search to see how many randomized trials there are out there about chat boxes, because we know an awful lot about it. There are precious few, and these two studies that you have heard really stand out in a number of ways. And really, one of my points is we need more randomized trial, with the paradox that it's not very easy or maybe even appropriate to do randomized trials with this kind of technology. And one of the great, I think, issues that we need to work out in our field is how we can begin to study and provide these interventions in ways that are adaptive, fleet of foot, as Brian wants to often has mentioned, to begin to build a deeper understanding of how to make them better and more widely used. I thought that by this time, just looking at the early results and what you were thinking, that these agents would be kind of integrated into the healthcare system. What's happened in the United States is they've gotten integrated in mental health in many ways outside of the medical system for really dealing with quite superficial problems. So while I was listening to these two wonderful talks, one of the companies that I work with, I thought, well, how many people actually use the chat box that I've been involved with that has, I have to tell you this, except for the study that I'm doing, and I haven't even published that, zero data. And they claim 20 million users, right? And they say that they are really dealing with all of the mental health problems. So maybe they are, maybe they're not. But the gap between the use and little bits of conversations that are incorporated into our daily lives that have great potential, and really understanding the impact of these is probably one of the largest gaps in all of medicine. So I do think as leaders in the field, we need to do a somewhat better job of doing the work that you've been doing, Brian, Enying's been doing, your team's been doing is spectacular. And even more broadly, thinking about why is it that they haven't done better than they have done? Why are we picking some of the easier problems rather than the more complicated ones? And what is the sort of gap between the promise and the reality of actually making it happen? So it's very exciting. And just one thing I want to say that when Brian was first doing this and was thinking about doing these diabetes programs for older people, I thought, no way this is going to happen. This is not possible. And when I looked at some of the early results and confirmed by the wonderful stuff that you presented tonight, that in fact, these aren't really, we have to be very careful about whatever biases we make about what and how and who is going to use technology and benefit from it, because you just saw evidence that populations that we thought would be very left out of the technological solutions are doing well in many ways. And why? Because these programs are very thoughtfully designed. Going forward, AI looms in. In the US, everyone thinks they have an AI program to make these chat box better. I think we have to be really careful about that. I still believe in the human design factor. And if I had my bias, it's really working very closely with partners and consumers and developing conversations and materials that are done on a human level, often with the scripting written by humans, rather than relying overly on automation to achieve conversations. So those are some just thoughts off the top of my head, but most I just want to congratulate you and thank you for this really fantastic and inspiring work.
Wow, thanks, thanks, Bar. I'm glad we invited you to be the discussion. There's a few comments in the chat, but I'm hoping that others have been stimulated by your comments as well. So if people want to put up their hands or just write something in the chat, feel free to do so. There's an exchange between Joanne and Ying about questions about the analysis and so on, which I think Ying's partly answered that. The question, the point that Joanne makes about clinical versus statistical significance and just the real clinical significance of the results. I think that's a fantastic question to ask, and we've not been able to get the kind of funding we need prior to getting the funding for the CRE and other research funding we might leverage off that. We've not been able to get sort of funding to do the longer term follow-up. I mean, at least for the TLC diabetes, it was equivalent to a sort of almost a 1 full point difference in HbA1c between the the TLC group and the routine care group, which if that difference was maintained over time along with other changes, I think that could be quite clinically significant and important. The other question you ask, Joanne, about how to get longer term sustainable implementation and financial models and so on. I mean, that's what I dream about, and that's the work I think, I mean, that's really one of our primary aims for our centre, isn't it? To kind of understand how we can get better integration into the system. Although, as Bar says, maybe there's a bit of a paradox there as well, because I think in the mental health field, these kinds of interventions and chatbots, but even prior to that, online interventions and so on for mental health, people were accessing in part because they either didn't have access to the health system or they were not happy with what the health system offered, So maybe there's a bit of a paradox there that we need to think about in terms of chronic disease management. Ideally, obviously integrating with the care people get from their GPs and so on, but a lot of the care that people get from their GPs isn't particularly good, and they go hunting to find other ways that they can, self-manage by themselves because they can't get that help and assistance from the health system. So I think there's a bit of a paradox there, which often we don't want to know about, but I think that is the reality.
I think one thing about the paradigm of the p-values and looking for clinical changes. We have models, and you all know this, I don't have to go through all the details, where one could think of, let's say, well, Joanne, you give us a target to achieve, and that really the goal of the research and the design would be to get to some clinically significant target. That's a very different research approach than if you simply take a randomized controlled trial, because the nature of trials, as we all know, are very limited to what you're going to be able to find. And even worse, when you think about 15 years of this work, Brian, you've got 2 fantastic studies. If you had sort of your hands untied, what could have you accomplished if you had had a whole series of iterative, fleet of foot kind of studies, and you really, every time you got to the point where you are with TLC or with My Diabetes Coach, you say, that's now the control condition. The next treatment for the next 3 months is going to be some better version. And when that better version hopefully achieves something, then we're going to try another better version. So we got to remember that technology has both the downside of it being everywhere and complicated and so much noise, certainly in the United States, but it also has the potential to move much more rapidly towards the kinds of goals that we all think are important. And I really like Joanne's comment in general, because I think we need to really be rigorous and force ourselves to push harder towards clinically meaningful outcomes with our technology.
Thanks, Bart. Just to the comment from Anne Claire about how the avatar was developed. Happy to discuss that offline, but yeah, a lot of co-design work, actually probably about a year's co-design work and effort, and why a woman was chosen and so on. Potentially now there's possibilities of people developing their own avatar and choosing their own gender and personality and so on. But on the other hand, I really like Wendy's comment. I love that it's not a super intelligent system and it's still so useful. I mean, that's what floored us with TLC diabetes. Like, for all of its imperfections, and I'm sorry you couldn't hear the conversations, that I didn't have my screen set up properly for that, but slightly clunky speech. I mean, the point is, and we kind of know this from 100 years of psychology, if people engage with the program or with a therapist, then they're going to kind of build into that relationship all the other personal features which are important and meaningful for them. So actually the technology doesn't have to be perfect. It's got to be good enough and easy enough for people to access it, interact with it, and feel engaged with it. But then they'll make of it what they will. And if they're motivated and engaged enough, then they won't worry about the imperfections. You know, if there's some words they don't understand and so on. So I really like, because I think often, you know, perfection is the enemy of the good. You know, we think with our technology that one day we're going to wake up and we're going to have perfection, and it's not going to happen, because we'll wake up and the technology's moved on and left us as researchers even further behind. Joanne's made another comment about integration with the health system, about someone having to pay to keep, the mHealth operational. I'm sure Bart could talk about this endlessly. The platforms that sit, people kind of imagine, in one sense, the unit cost of delivering a program for someone to access isn't very expensive. But if we're really going to be able to manage and keep up with the technology curve and the platforms, the costs are significant, you know, and that's sort of something that health system managers and decision makers don't understand. They think it's just someone accessing an app which is for free, you know. So I think that's an issue. Did you want to comment about the ending the comment from Shariful, or did you do that? Oh yeah, okay, you've done that in the chat. Yep.
Brian, where do you see yourself going with this?
Well, we've got the CRE, you know, so I think it's to scale, you know, what's possible to take to scale, and how is it possible to link and integrate more with healthcare delivery, I think. Jonathan, I can see your hands up. Did you want to talk?
Yeah, I wonder, Brian, how you see this fitting in with what you mentioned at the start, that kind of big vision of delivering care to large-scale populations, and how you see this fitting in. Do you see this being something that everybody gets, or that some people get, and in particular relating that to the tapering engagement over the intervention period? Might that suggest that there's a few people that really get on well with it and they keep using it over time, others try it out, maybe it's not for them and they move on. So just your thoughts on whether this is something that truly does go across the population, or whether this is not necessarily niche, but a bit more targeted.
Yeah, it's a great question, Jono. My quick response is, I think, aren't most people who are interacting with the healthcare system, particularly for chronic conditions, they're using technology to some degree, aren't they? Like they're at least going online and checking out stuff. And there's a lot of evidence that people are interacting with other kinds of organisations and support. So I kind of see what we're talking about is just a further iteration of that. It's kind of systematising resources and supports for chronic disease management. So I kind of don't even see it as so qualitatively different from what I think the majority of people are already starting to do. And if they're not doing it for health, they're doing it for a lot of other areas of their lives, whether it's booking a restaurant or doing anything else. So I think the sooner we kind of normalise kind of using these kinds of programs and resources and supports in healthcare, the question really then comes back to Joanne's point about how can there be more funding support to make sure that programs are evidence-based, and you know that there is triaging involved and moderation and clinical alerts and things like that. You know, so I don't see this as an alternative to human-delivered healthcare, but I see it as being supportive and complementary.
Thanks.
Happy to follow up with any other comments or anything else. Bar, final word from you. Did you want to make any comment?
Well, thank you again for everything you're doing. I'm pondering the issue about whether we need to, you know, one of the problems of having stable systems where we can do that is a problem worldwide, and it's been surprisingly unsolved. So we have been recommending in the US that people begin to try to fund some sort of a platform that is accessible. But I think that's definitely one of the limitations. So thinking through how we can, from a policy standpoint, also have governments, I think part of it has to be done by the governments to provide the resources and sustain the platforms that could be used for all kinds of purposes.
I'm waiting for our colleagues in Denmark, Nana and her colleagues there, who you guys are going to solve this problem, aren't you? Isn't this sort of the Nana, I don't know if you're still on the line, but with the program you're developing in Denmark is really about developing a sort of platform which is actually integrated into and linked very much to the healthcare system, you know, which I think ultimately is the only way that there would be sufficient resourcing and expertise to really run a proper platform and make sure it's agile enough to keep up with the developments.
Well, yes, we are in the process of implementing a program into the healthcare system and trying to find out new models how to work together across sectors and having new functions. So yes, we are in particularly focused on that point in terms of implementing into the existing system and with new models. Yes, yeah. Digitally supported interventions. So that's our focus.
Yeah, so that's why we're so excited with what you're doing, because you're way ahead. Or I think you can possibly kind of crack that nut in a way that seems to get even further away in Australia. And then there's some other fantastic developments in China in particular that Enying knows about, that really scaled up interventions as well, which are quite exciting for the future. But we've come to the end of an hour, so I think we should probably finish there. But if people want to follow up, feel free to do so through our CRE, and keep in touch, and we'll sort of update with the next webinar, and or if you've got suggestions for other topics or ideas for presentations, please feel free to pass those on. Thanks so much, everybody. Thank you all. Thank you all. Thanks, Bar. Thank you, En Ying. Thank you.